Okay, there you go. So this is going to be our 2024, kicking off our 2024 data submission. This is the training that we do every year that is just going to run through what we're expecting for the data submission for the 2024 cost growth target for the payers. So we know that this year there's another provider-based submission that is possible. That's for the frontline worker compensation. That's not going to be for this training. This is for the payer submission. And we'll have more information about the frontline healthcare workers in future communications, and we might even do a whole training on it. We'll let you know. Um, so this year we're going to be covering, we'll go through the whole data submission template and any changes that we made to the template so that everybody knows. But we're going to go through everything for anybody that's new or for any. I don't believe we'll have any new submitters, but for people at the payers that are new to doing this or just want a refresher. And we're recording it, so we'll probably be posting this somewhere eventually. So let's get right into it. This is a virtual meeting that we are going to record. If you can, I think it's generally helpful for everyone to just put your name and your organization, first, last name, and your organization that you're with in the chat, just so we have it recorded. It really helps us to know who is here and who we need to maybe reach out to. Um, if you have any questions, feel free to use the chat function. You can also raise your hand. This is going to be a pretty, I think, we'd like to make it relevant for you. So if there's something you need us to cover and we haven't covered it yet, you can go ahead and let us know. Either at the end of a section or at the very end. We'll hold quite a bit of time for questions. Um, and we're still seeing people trickle in. So I'm glad we're getting such a good number of people that are coming to this. This is, though, for technical staff. This is going to be a very technical meeting that is all about the actual data submission. So we have a lot of different types of meetings. We have tag meetings that are fairly technical, but we have a large group of people that like to come to those to stay up to date on what's happening with the program. But this one is really going to be pretty specific to the actual data submission and what you folks need to do, what the payers need to do to get us the data in the manner that we're asking for. And so this is payers only, public and private payers. So I think I see, or maybe our fee-for-service crew is on here, our Medicaid fee-for-service crew. It's good to see them. Uh, and so the data submission, as a reminder, is going to be due in September of this year. And I think we'll have a slide later on the exact dates that are upcoming. But just for anybody that wanted to jump in and just be reminded of when the data submission is and what it's for, it's the 2024 data submission, which is for 2022 and 2023 data. And it's going to be due in September 6th of this year. And we're going to really highlight any of the changes specifically. So we might go a little fast through some of the stuff that hasn't changed because I think everybody's going to be familiar with it. So we can make sure to cover all the stuff that there have been some substantial changes to two areas specifically. So um, the we are going to cover an overview of the program like we usually do for this, just so everybody's grounded in what we're here to do. Let's talk about the schedule and then actually get into what we're expecting all of you to submit once submissions occur in September. So Oregon, as a reminder, was the number 4 state to have a cost growth target, but we're growing every year in terms of the number of states that are doing cost growth targets. So for some of you large payers that are national, that aren't regional, you're going to be very familiar with this. There are probably more states asking you for these submissions every year. And once California came on board this past year, that means that 20% of the country is the people in the country are actually covered by a cost growth target because of just how many people have joined with California being a member of the cost growth target world now. Um, the in 2019 was when the Senate bill passed, and then they spent 2 years coming up with the rules, the final recommendations for the cost growth target. So in 2021, the final recommendations report was submitted by the implementation committee. There's a lot of great resources. We have all of this on our website. There's a website right there, or you can just Google the Oregon Cost Growth Target, and you'll get our website. And there's a lot of the background as to how we came up with what we're asking you for and what we're measuring and what we're going to do with that information. Trang, I see that you are on now. You hear where I'm at. If you need to add anything, you can go ahead and jump in. But I'm just going to go ahead and keep making my way through the intro until the next section. So there were a lot of goals. There were a lot of recommendations made by the committee, and we went with a total per capita 3.4% cost growth target that applies to all payers and all providers. And the way that we interpreted that is, we are having to exclude some payers and some providers just because of how small they are, but we are really supposed to be holding 3.4% to every payer and every provider in the state. And that's aligning with all the incentives and everything that we have in all of our different programs, including Medicaid. So there's been a lot of tweaks. We're still tweaking it every year. There's some new legislation this year. There's new legislation every year, but this meeting is going to be covering the most up-to-date information. So if you've been relying on the old meetings to have a regrouping of what we're asking for, maybe this one is the one to use instead, because there are some new updates that we have. And as a reminder, 3.4%, that's the number that we're shooting for. This isn't going to be relevant to the actual data submission. You don't have to measure 3.4% on your side and report whether you met the target or not. We'll do that. You just submit to us the data that we're asking for. This is an aspirational goal. It's not a hard cap. There's no budgeting. There's no separate hospital price caps. There's nothing like that. This is for every single payer, every single provider that we're trying to hold accountable to the same number.
I'll just add one thing, Sam, to that 3.4% growth rate. So as Sam said, it is what we're aiming for, but of course we understand there are certain types of services where we do want to see more growth. Certainly more than 3.4%. So it's one thing we like to say in the program a lot is not all cost growth is bad or controllable, but having that 3.4 as something to aim for and having the data coming into us the way it is, it's helping us see where there are areas of growth. If it's not something we are particularly excited about, maybe it's an area where we're actually a little concerned about. This program is where we can start to dig around and see if there's something we can do about it at the state level. So go ahead, Sam.
Thank you for that, Trang. That's a good thing to keep in mind. Trang, do you want to just keep going? This is your slide, so I know you'll have a lot more information about this.
Oh, sure.
Okay.
Thanks. All right, thanks everybody. Thanks for joining us today. So as you can see, this is the annual program cycle envisioned for the Cost Growth Target Program. Those of you who have been with us, this is the 4th year we're collecting data. This will be very familiar to you. And if you're new, welcome. And also, it all starts with the data we receive from your organizations come September. This is an annual data submission cycle. September in the fall is when we collect the files. We start to validate it, measure it, and then eventually report on it in the spring. And then those last two spokes on the wheel, the identify and implement, that's where the action part of the program happens. So as you can see, it all depends on having good data coming in. Next slide, please. All right, so this is just a snapshot, a reminder of the annual due dates. They're technically different dates each year because it is the first Friday in September. So this year in 2024, that is September 6th. And another reminder, we need to collect 2 years of data every year. So this year we are collecting expenses for Oregon residents in 2022 and 2023. Next slide. All right. So let's get into an overview of the data captured before we funnel down and get to the actual template and what the template looks like. So in the Cost Growth Target program, it receives a lot of data from different sources. This diagram right here is just to show you some of the terms we use. If you look at some of our past reports, you'll see the term total healthcare expenditures. That is made up of two major components, total medical expenses on the left-hand side of the diagram and NCPHI, net cost of private health insurance. The CGT1 template, those files we receive from you all each September, that is getting us the total medical expenses made up of claims and non-claims payments. Next slide, please. All right. So this slide, kind of familiar for those of you who have been with us since 2021. This is just a quick overview and a snapshot to show that there are a lot of dollars in the healthcare system. Total medical expenses doesn't capture all of it, but it does capture the core medical expense payments, these allowed amounts, these negotiated rates coming into provider organizations from insurers for insured Oregonians. So that's just what these three rectangles kind of on the mid and right side of this diagram, that's what TME represents. And then you could see net cost of private health insurance there at the bottom. We do receive that in a separate data stream, not related to the CGT1 files. Next slide, please. Okay, so I kind of already mentioned a little bit of the data we captured. So just to summarize, these are medical expenses for Oregon residents who are insured, and where you, the payer, is their primary, you are the primary payer. There is an asterisk, and that is, you can see at the bottom, that is the dual member caveat. So the way we report expenses for dual members is a little different. Whether you are primary or secondary, all payers, if you have a dual member person, you will report for them on a paid amount basis. And that's because of a particular way our state plan amendment operates in Oregon. We need to collect dollars on a paid amount basis to collect the totality of their dollars. And we could get into that if people have questions, but that's a little quirk with duals. So Oregon residents, we're looking at three markets, Medicare, Medicaid, and commercial insurance. Later on in the presentation, we'll go into more detail about the lines of business. There are 6 lines of business, but roughly Medicare, Medicare Advantage, actually, Medicaid and commercial is what we're looking at. And this is for their care, any Oregon resident, any care, regardless of where they received it, in or outside of Oregon. Please do not submit out-of-state residents in these Oregon files. Next slide, please. All right. And this is just to show you kind of a really quick workflow of what we're looking at. So from left to right, we're looking at Oregonians, and you, the payer, and we'll go over attribution, but the aim is to attribute your members to a provider entity using a primary care-based methodology. Not everyone is going to be able to be attributed to a provider entity, and that's okay. But the aim is to attribute folks, and we in this state we do have, compared to other states, a pretty good rate of attributing people. Um, so people to provider entities, and then once that happens, the spending associated with that member for those measurement years, those get allocated to 9 claims and 6 non-claims categories. They are mutually exclusive categories, and we will get to them in a little bit. So that's kind of the workflow of capturing the dollars, attributing the dollars, and then allocating the dollars to the separate service categories. All right. So now let's get into the data submission template. If folks would have, oh, you know what? So another note we want to say, I don't know if Sam mentioned, we are releasing the data template this week. Apologies for the lateness. Usually we like to release the manual and the template together, but we had to check some things with the template. So I guess what I will say is after this webinar, the slide deck will be posted, and also the template. And if you want to look at those side to side, that might be a good idea, because there are some little notes and data points we pulled out that are in the slide deck. That would be, it would be good to have it and then look at the template on your other screen, or just, next side to side on the same monitor, if you get a little confused, because if you're new to this, it could be a little confusing about the layers of stratification. But I'm going to go through the template right now and pretty much go through tab by tab, about what is happening in each one. All right, so I'm going to go ahead and share my screen. And actually, since I do, let's see, my monitor, oh, I wonder if it's big enough I can actually show both the slide deck, and I think I'm actually going to do this. All right, so I'm going to go ahead and share my monitor. Sam or Yishan, can you let me know if it's too small? If it's too small, I'll go ahead and just share the template window.
Hey, Tran, this is Ishan. So I feel it's very, very small. I'm not sure how about
Okay.
you feels, and so maybe just one.
Okay, so let me just share the window. Let me stop sharing here. Thanks. Okay, bear with me while I share my, okay. Here we go. Okay, can you see this all right?
Yes, it works for me.
Okay. Okay. So let me just rearrange myself here for a second. All right, so let's get to this. If folks have questions, also, Sam probably mentioned this, you could wait to ask them at the end, or if you want to put it in the chat, feel free to. Although you might want to hold off because we may answer it later on in the presentation. All right, so what I have open is the 2024 data submission template. For those of you who have seen this before, and all of our data reporters have submitted files to us previously. So you might notice there's not a lot changed, except we did add 2 new tabs. Reporting for all the other tabs is largely the same, but these 2 new tabs for medical pharmacy, and we'll go through this in the webinar. This is where we're asking you to pull out a subset of spending from your claims data to populate these tabs. So let's go through it. Running along the bottom, this is basically just a descriptive table of the tabs. The tabs TME All, TME Prov, and TME Unattributed, these are your primary total medical expense tabs. We do collect other data in the other tabs, but as far as claims and non-claims spending, all that information will be in tabs 2, 3, and 4. So let's go ahead and get started. All right, so the cover page. So the cover page is, ooh, I should expand this. So the cover page is comprised of a series of tables where we ask you to, let me do this. They're just basically little checks as you're compiling the data to make sure that the claims and the way the expenses are allocated and coordinated, if it's done correctly. So you'll just see it's most of them, I think, are a series of yes and no responses, and will prompt you in the question whether we need additional comments when going through your file. A question a lot of people have is this attestation part. Who should attest to this file? And we don't have a particular title or role for the individual that needs to attest to this, but it should be someone at your organization. It could be a data analytics manager. Sometimes it's the CFO or something. Somebody with some level of seniority that can attest that these spending amounts are appropriate and submitted to the best of payers' ability. So I think that's all. Yishan, do you want to say anything about the cover page? It's pretty straightforward.
Yeah, I agree.
Okay.
Yeah, I don't have anything to add. Thanks, Chen.
Okay. So let's get into the TME. Let's get into TME All, and I'll just be going through the tabs in order. And this is the same order as the slide deck also. So TME All is going to be, when we refer to TME All, Prov, and Unattributed, these 3 tabs are related to each other. Basically, if you're looking at spending by reporting year and line of business, TME All is basically the sum of the amount in TME Prov and the amount in TME Unattributed. TME Prov is data that you were able to attribute from a member to their provider organization. If you were not able to attribute a member to the provider organization and you just had their claims spending, you would submit it in TME Unattributed. But TME All is, the sum of them. So it's usually not as long as these other 2 tabs. You can see running along row 9 here are these columns. If you look at the other TME tabs, they're very similar. Here are your 9 claims columns, and then you have your non-claims columns. Later on in the webinar, we'll go over the specific page in the manual where we talk about the descriptions of these categories. One thing to note in the template, if you're looking at the template for the first time, perhaps, the columns in blue are auto-calculated, so you don't have to do anything. I think they may also be locked for you all. So just know as you're filling in data for the columns A through S, the blue columns will populate. And I think we have, yeah, a note up here. At the tops of each of these tabs, you'll see little comments of how to populate it, or when there's a cell of concern. Some of our validation checks, for instance, will use a red cell highlight color if the formatting is incorrect. So for example, in this tab, if you've entered data that is not formatted correctly, so say for instance, claims professional specialty providers, it's asking for a non-negative number. If you put a negative number in here, the cell will show up red. So that's an example of one of the checks. Let's go to TME Prov. So this tab houses your data where you were able to attribute a member to a provider organization. So in this tab, you'll see these 3 columns: provider organization name, IPA or contract name. We'll go over that in a little bit because this column is new. And attribution hierarchy code. If this hierarchy code, if this is new to you, hang tight. We'll go over that later as well. But I wanted to show you, you could see how similar these data fields are to TME all. The difference is, as you might guess, there's going to be a lot more rows in this tab because we have provider organizations, hierarchy codes, and the data will be stratified by those also. So stratifying the data by reporting year, the line of business, the provider organization, IPA or contract name, if you have that, and hierarchy code. The demographic score we will hang on and discuss, but like previous data submissions, Oregon Oregon provides payer staff demographic factor tables, and we have you calculate a demographic score for each row here. And the demographic score will also help you calculate, and we're going through the claims and non-claims data fields. That will also, the demographic score will also help you calculate this column, the standard deviation per member per month. So that is the TME Prov tab. This tab, because we get data, we have a lot more rows in this tab because of the stratifications by some of these data fields in the beginning. This tab is a lot longer. I believe we have 20,000 rows. And so far that has been enough for payer staff. If for some reason, I don't think you should go, I'm not really sure. If you are compiling your data and you are, and if this tab, if you're running out of room and if you need more than 20,000 rows, please reach out to us, email us, because I don't believe you are able to add rows yourself because this sheet is locked below that. Do you want to add anything, Yishan? Yeah. Okay. So hopefully that should be plenty of room for folks. Okay. So going over to TME unattributed. So let's say you have some members, you were not able to attribute them to a provider organization. We still need those expenses. We still need that spending from you. And this is the tab you will enter those folks in. So you will aggregate them, and in this tab, it's only by reporting year and line of business. So this is a fairly short, in number of rows wise, this is a fairly short tab. So you can see this is very similar to TME All. We have reporting year and line of business, the total number of member months, a group demo score for this row, and then you'll see the claims and non-claims here. And then standard deviation, and then the blue auto calculate fields. Okay. I'm going to, okay, I'll stay here. All right. I'm going to go to market enrollment now. So in market enrollment, we have a couple different, sorry, hold on. So in market enrollment, we have a couple different, oh, actually, no. Let me pause here. So while we're not gonna go in, we're gonna complete the other tabs later, but after doing the TME Prov tabs, let me hand it over to Yishan to go over the standard deviation. And Yishan, let me go ahead and put the, or Sam, are you on slide 31 of the PowerPoint?
I sure can be.
Okay, thanks. I just realized my setup is a little funny.
Yep, I'm sharing, Ishan. Just give me 1 sec.
Okay.
Sure. Thank you. Yeah. So hi, I'm Yishan Song, she, her. I'm a data analyst with Cosmos Target Program, and I'm just to go over the methodology, how we calculate the standard deviation, which you will put the standard deviation numbers in the tab 3 and tab 4. Sam, do you mind if I screen share the standard deviation example
Yeah,
in the
please.
Excel sheet? Yeah, thank you. Let me do that. Second. So you just give me 1 more second to do that. Okay. Can everyone see my screen okay?
Yeah.
Yep.
Okay. Yeah. Great. So the purpose of we collect the standard deviation is to get the confidence intervals for the cost growth rate from year 1 to year 2. And the confidence interval is applied to make sure if the cost growth is really over the 3.4% with statistical confidence. And since we didn't change or update the standard deviation methodology, so it is basically the same as you did last year. But I'm still going to go over a few steps, how we do the standard deviation. And before I go over these steps, just a few things to highlight. So first, when we do the standard deviation, we are using the demographic adjusted dollars to calculate the standard deviation, which is different from the dollars you report in the template 2, 3, or 4, which the dollars report unadjusted by service category. But when you calculate the standard deviation, we do need to use the adjusted dollars amount for member months. And then the second, when you calculate standard deviation, we only use the claims payments. The non-claims payment should be totally excluded from the standard deviation calculation because we are trying to capture the variations between the claims and between the members and not focus on the non-claims for the standard deviation. And third, for standard deviation, it is on a per member per month basis. So the standard deviation is not at the member level for the entire year, which means you will need to calculate the per member per month first for each member before you do the standard deviation. And one last thing, when you do the standard deviation, you need to make sure you use the equation, which is for the population standard deviation. That means the denominator is the big N. I know there's another equation, which is sample standard deviation, which the denominator is N-1, but you really need to just use the big N, whatever number of member months you have for that provider organization. So let's start from the step 1. So in this example, we use a commercial for claims, but you can use it for any other lines of business. The logic is the same. So for step 1, we first need to attribute the member months to the provider organizations using the attribution method we put in the manual. And for the member months that are unable to attribute to any provider in that given calendar year, then you will need to move them to the unattribute category. So in this example, you see the member 1, it has 8 months covered by another payer, which you don't have a visibility about that payment, what that payment was. In this case, you only need to report that members per member per month PMPM for their last 4 months where they are being covered under your plan. And another example is member 5. So it is possible that members may switch from one provider to another provider in one calendar year. And in this case, you will have 2 different PMPMs for this member. Like member 5, you see it has 1 PMPM for the hospital system Z and then 1 PMPM for the Main Street provider group. And similar to the member 7, it is possible that the member may be attributed to one provider, but then become unattributed during the year. So in that case, there are 2 different PMPMs for the member 7 as well. So that's step 1. Let's go to step 2. So once we are done with the member months which attribute to the proper places, the step 2 is to calculate the demographic adjusted PMPM. In this example, the member 1 only has 4 months being covered by the plan. So the PMPM is sum of the payments in the last 4 months. So we get, and then we divide the sum by 4, which is the number of member months. And then we get the unadjusted PMPM, which is 225. And then to get the adjusted number, we need to use this number divided by the demographic score. So we will get adjusted number, which is 174.42 for the member 1. And we can use the same logic for all other members. Here, I just want to add that for member 5, because the first few months in being attributed to one provider and then switch to another provider. So that's why you will see 2 different PMPM for member 5. And same for the member 7, because it switched from the provider group to unattribute category. Then we also have the 2 different PMPM for this member. Okay, so That's for step 2. Let's move to step 3. So once we have adjust the PMPM for each member, then the step 3 is to calculate the total member months and adjust the average PMPM by line of business, by provider organization, and by attribution. So let's use the hospital Z attribution, the tier 1 as an example. So the total member months is pretty straightforward. You just sum up the numbers here for the hospital Z tier 1. And you will get 28 here. And then the next step is to calculate the adjusted plans spending. So for this example, it's basically we use this number multiply for the member months for the member 1, and then these adjusted PMPM multiply 12, and stem here 12 multiply this number, and then you will get adjusted total spending, which is 7,069.89 for the hospital Z. And this is the total spending. So if we want to get a PMPM for this provider, then you will need to use this number divided by the total member months and then get the 252.5 for the hospital Z tier 1. And you use the same logic to get all other providers and also the unattributed category for the numbers. And here I want to say for step 2, you see the XI here, and then the big N, and then X bar here, which will be used for the standard deviation equation, which you see the step 4 here. Okay, any questions so far? I feel I've been talking a lot. Okay, so yeah, here's the standard deviation equation. The X bar here is the X bar in the step 3, which is the PMPM at the provider organization level. And the big N here is the total member months you see in the step 3, which is the total member months for that provider organization. And you also see this XI. This is also the adjusted PMPM, but it is at the member level, which is in the step 2. You see here, 174.42 for member 1 and for all other members. And here I want to note that for the XI, it is not the actual dollars you pay for that member in that given month. The XI is the PMPM, it's the average payments for per month for that member, which is the average. And the purpose of we use the average and not the actual dollar is that the standard deviation is trying to capture the variation between different members. We are not trying to capture the variation within the members but different months. So that's why for one member attribute to one provider organization, we only use one value of their PMPM. So you will see for member 1, because it is being covered for 4 months under the payer, so you will have the same PMPM for member 1, and then member 2 and member 3. So we use this PMPM and then apply this number to the standard deviation, and we will get the number, which is the standard deviation is 31.92 for the provider organization, for the hospital system in this case. And for the case that members being attribute like switch from one provider to another, like in the member 5, like for member 5, you have 2 different XIs, which one is for the hospital Z, and then one is for the Main Street provider group. So that's for the step 4. And then the last step, what you need to do is to put these standard deviation numbers into the template, which if it's the member months attribute to the provider organizations, then you put the numbers in the tab 3. And then if it's for the unattribute categories, then you put 8 in the tab 4. So any questions so far for standard deviation? If not, I'm going to stop sharing and I'm going to hand it back to Tran.
And Sam, can I ask you to screen share again?
Sure thing.
You have it up. And can you go up to slide 22? I just want people to see that the slide deck. So the slide deck, which we'll release after this webinar, it does have as we're going through the tabs, it does have sort of like the headers. So again, if you have this slide deck open and the template open side by side, it helps kind of synthesize everything a little bit more. So I just wanted to show what that looks like in the slide deck. So here is a snapshot of TME Prov and all of the fields that are relevant for this tab. Can you go to the next slide? Again, this is like what I mentioned, but maybe visually this is a little easier to digest for folks. Looking at TME Prov, you could see how the fields are the same, except we're missing the provider organization attribution fields. So looks exactly the same as TME Prov, except there is no organization name, no IPA or contract name, and thus no attribution code, but we do have reporting year, line of business, member months, and so on. Next slide. And this is just, again, looking at TME All. TME All is going to be, by reporting year and line of business code, it's going to be the sum of TME Prov and TME unattributed. And those grayed out boxes are just denoting that you don't see those fields in this tab. Can you go to the next slide? And I don't want to spend too much time, but we did have examples of how that stratification looks for these TME tabs. So if you look at the slide deck, we have an example of what the stratification looks like for TME Prov. So if we're stratifying by reporting year, line of business, provider organization name should also be highlighted, so we'll fix that, as well as IPA or contract name and attribution code. You can see how many rows one provider organization may have. So if you're looking at physician practice X, you can see they are listed, let me count, 1, 2, 3, 4 times. So they're listed 4 times because we're stratifying by year, business code, whether or not that IPA or contract name field is populated, and then also by attribution hierarchy code. Next slide. And this slide is showing TME unattributed. Because we don't have any provider organization fields, we're only stratifying by reporting year and line of business. So just, yeah, thanks. And then the next TME all, again, just year and line of business code. Next slide. Want to make a note about the line of business. So we have 6 lines of business. Yishan mentioned this when she was going over the standard deviation, but members, they can change, their benefit situation within the year. And so this should also be reflected in line of business. So that's why we're collecting this data using member months. So allocate those member months as appropriate. For line of business, you can see there's Medicare, so that's Medicare Advantage. Medicaid is line of business code 2. Commercial can be split into line of business 3 and 4 based on whether these are members with full claims or partial claims, and we'll go over what that means later on. But those 2 lines of business are commercial market. And then the last 2 line of business codes, 5 and 6, are for dual members. Line of business 5 is for Medicare expenses for duals. Line of business 6 is for Medicaid expenses for duals. And you can see the note there. All payers, whether you are the secondary or primary, should report for dual eligible members in line of business 5 or 6 using paid amounts. Next slide, please. All right. This slide is just talking about the different 9 claims categories. If you want to look at the descriptions for those, please see manual pages down there, 37 to 40. Next slide. So those are the 9 claims categories. We also have 6 non-claims categories. Descriptions also in the manual. For folks that may submit the payment arrangement files to the APAC program, you'll note that we only have 6 non-claims payment categories, and in APAC we have a lot more detailed categories. So just know that for this data submission, read through those descriptions and categorize your non-payments correctly. Some of these are going to be a lot broader than what you find for the payment arrangement file. If you don't know what that is, don't worry about it. Next slide. All right, this is just reiterating some guidance regarding standard deviation. Links to Yishan's really nice walkthrough are there. They've been up on our webpage for a while, and a full description of the statistical methodology is also linked. Thanks. Next slide. Let's go. Okay. I think before I'm not going to go through, I'm not going to screen share market enrollment because it's a pretty simple tab. But there's been no change to this tab from previous years. So I guess the only thing I want to say here is that when we are populating for the market enrollment tab, just note that these categories, there are 8, they're not the same as the line of business tab. So just keep that in mind as you're populating the member months in here. I think that's all for this tab. And at this point, I will hand it over to Margaret to talk about our new medical pharmacy tabs. Margaret, if you want to go through these slides and then screen share, and I can screen share for you, and then screen share the template, yeah, we can do that. Do you want to do that, or do you want to jump right to the template?
Chen, so Margaret is actually out of sick today, so I'm going to present the medical pharmacy. I know, yeah. So I'm going to walk through the medical pharmacy section, and yeah, Chen, when I go to the template part, would you mind to share that while I'm talking? Okay, sounds good. Yeah, so so early this year, we had the medical pharmacy work group, and then came up with the data template for the medical pharmacy. We have also shown this template during the last 2 tech meetings as well. So starting from this year, the 2024 data submission cycle, we are requiring payers to provide additional breakout for the medical pharmacies claims, the total expenses, which is to allow states, payers, and provider organizations being able to track how much of the spending is going to a drug administrator or provider in a clinical setting. So look, we provide a code list for the medical pharmacy. You can use the link in this slide, which the list is constructed by we use a CPT and the procedure codes for medical pharmacy in the average sale price files from CMS. And then we also have used a separate payable drug list in the outpatient prospective payment system and addendum B. We also use the codes, the HCPCS and the NDC costs were maintained by the Medicare's contractor for pricing, data analysis, and coding. So we came up with this code which you can use to pull out what the medical pharmacy payments are from your claims data. And then the medical pharmacy payments are reported in the tab 6 and 7. So Trent, do you mind to share the template just quick? Thanks, Trent. So yeah, the medical pharmacy payments will be reported in the tab 6 and tab 7. The tab 6 is for the medical pharmacy payments that are you able, like the member months are able to attribute to a specific provider organizations. And then the tab 7 is for the unattribute member months. And you will see the columns, the columns, which is very similar to the tab 3 and tab 4, because we do need the similar breakout for the medical pharmacy costs that we do in the tab 3 and tab 4 for the claims payments. And also I want to mention that in this new tab 6 and 7, it's not mutually exclusive from the tab 3 or tab 4 you report. In the tab 3 and tab 4, it's the full payment, so you still report what you've been doing in the previous years, but the tab 6 and 7, which is just the subset payments, which you are able to classify these payments as the medical pharmacy, and then you put these dollars into the tab 6 and 7. And then we do the same breakout as I just mentioned. We do like claims inpatient, outpatient, primary care, and so on, which is very similar you see in the tab 3 and tab 4. And yeah, I think that's for the medical pharmacy. Any questions?
And if you have any
question.
Oh, go ahead.
Yeah, I just see a question in the chat. Just to be clear, the service should be reported. Yeah. Yeah, exactly. Any other questions? All right, and I think I can hand it back to Trent.
Yes, and since these are new tabs, if you do have questions, you know where to find us. Send us an email, and we're here to help. We want this to be as painless as possible. All right. Okay. Let me see. I'm not going to screen. I think I want to run through these. I want to go through these slides, and then maybe I'll screen share the template again, just because there is a lot of content on the slides. I think it might be easier to stick here. Pharmacy rebates, that is same tab as before, except now it's tab number 8 in the template. This information here is just summarizing what is already in the manual, so I'm not going to read through it. It's the exact same. So we do collect pharmacy rebates from payers. They should be reported. Down there, you can see total rebates should be reported without regard how they're paid to the payer. So whether that's through an aggregate payment or on a claim-by-claim basis, the rebates should also be a negative number. One thing to note for Medicaid CCOs, so for state Medicaid program, OHA is going to be collecting that pharmacy rebate separately, and we will apply these to the Medicaid market at the market level. So for CCOs, I think a lot of the time this tab is blank, and that's okay. If there are rebates your CCO has negotiated just yourself, of course, feel free to report those in here as well. But just to note for Medicaid CCOs, OHA has the pharmacy rebate for that. All right, next slide. Okay, here's some more information on the split between retail pharmacy and medical pharmacy. We do have separate columns to report rebates relevant to retail pharmacy or medical pharmacy if you are able to separate that out. Many organizations can't, and that's okay. And if that is the case, you'll see there's a total rebate field which you can use. Next slide, please. Okay, so this is just to talking about rebate estimation if you're not able to separate them out. I'm not going to read through this, but this is also fleshed out in the manual, and you can read about that later. All right. Oh, I see a comment also from Jeanette, and excluding retain pharmacy. Yeah, excluding retail pharmacy, correct. Retail pharmacy you will continue to report that under that particular claims category, retail pharmacy. Yeah, correct. All right. So let's talk about tab 9. So tab 9 is our provider organization identifier tab. In that tab, we ask for provider organization name and associated TINs. Let's go to, so basically, if you have a provider organization in your TME Prov tab, that's the tab where you're able to attribute members to a provider entity. So if that provider entity exists in that tab, they must also exist in tab 9 Prov ID. Let's go to the next slide. Okay, so this is kind of a snapshot of what it looks like, of what the Prov ID tab looks like now, given that we have an IPA or contract name field. So here's an example. Suppose in 2022, we have physician practice X. They have 3 TINs associated with their business. This is how they would look in Prov ID. So you could also note there's also a physician practice Y, just to add a little something extra. But you could see that physician practice X has renders services for some patients that are also a part of this total cost of care contract A. So they service some people under this total cost of care contract. And we can also see that they service some patients that are not a part of that contracting group. So that's why we see them multiple times in here. So if you look at the first 2 rows, physician practice X, total cost of care contract A, and they have two TINs, two of their centers or sites are relevant for this total cost of care contract. And so we can see the TIN listed 1 and 2. If we go down sort of, I'm looking at sort of a couple middle rows, physician practice X, the IPA or contract name is blank for these 3 rows. And if you keep looking to the right, you'll see the TINs associated are, once again, TIN, their first, second, and third TIN. So basically what that tells us is they have 3 TINs associated with their business. And here we're just trying to think of every single reporting combination that could exist from our conversations with payers. So in this example, we see they have 3 TINs total. 2 of them are associated with total cost of care contract A for whatever reason. And that's why we see them in the first 2 rows. It feels a little bit repetitive, but I'll just note reporting the data this way is necessary, because when we create that statewide file from all the payers, so when we create that statewide file and we have provider organizations that are, meet the threshold for inclusion in the program, some of the member months, some of the spending, it gets a little fuzzy when IPA groups or certain contracting groups are in play. And this past year, we've spent a little bit of time going back to payers, having payers resubmit data or clarify data, because some of their members were under, for example, under a total cost of care contract. And we had to think of a way to split those member months so we could talk to provider organizations and have data conversations in a way that made sense. Sam, do you want to add anything? I'm not sure if what I just said made sense.
I think you're saying it right. You're justifying why we need to do this. And we're going to get into more details like very quickly here. The thing I want to underscore here is that we just essentially need a provider organization TIN for every combination of provider organization and IPA name. So if that exists in your TME Prov side, then we will need a provider organization TIN for it. And that doesn't necessarily mean that the physician practice X in this case, like it doesn't mean that they have to have an associated total cost of care contract for every TIN. It just so happens that some of their data for at least a few members is under both of those umbrellas. And so because you're submitting them under both those umbrellas, we want to make sure we're grabbing the right provider organization TIN. So I see a hand. Was that Travis? Was that you?
Yes, sorry, this was just too hard of a question to try and type out. First off, does that IPA and contract name field, does that appear on tab 3 and 4? Yes,
Yes.
okay. Well, we have a member month threshold to whether or not we calculate or report somebody on tab 3, whether or not they have enough member months. If somebody hits to be reported on one line because of an IPA contract field, but then falls underneath the threshold on what's left over, do those then get shifted to unattributed?
Yes. Yes.
Okay, thank you.
Yeah. So yeah, good point, Travis. So he is referring to 12-month member month threshold. So if you have a row, so if you have a unique combination, of those multiple provider organization fields, if the total member months is below 12, you need to go ahead and remove that row and put that data in TME unattributed. Thanks for calling that out. All right. Let's go to the next slide. And I'm also looking at the time, folks. It is 11:12. So I think going over the template and the data field is always going to be the bulk of these webinars, but I will try to go through, the rest of the slides at a somewhat faster pace. It's a lot easier because we're just calling out sections of the manual after this point. So, all right, here we go. So this slide is just talking about how multiple tabs in the data template are related to each other. So like before, I mentioned how tab 2 is the sum of tab 3 and tab 4 per unique year and line of business. We'll discuss more in when we go over what validation looks like. There are validation checks in the template where you can check to make sure that, the rows are summing up appropriately. If you look at this periwinkle purple arc, it's saying that the total member months per year in TME all, they should align up with the total member months in your market enrollment tab. And then the green arc is denoting what I mentioned before. If there's a provider organization name in TME Prov in tab 3, it should also exist in tab 9, Prov ID. All right, next slide. And we just want to touch on some places in the manual where there is more content for folks to use as a resource. All right, let's go to the next slide. Next slide, please. All right, so there are certain hard rules for data submission in the Cost Growth Target Program, but there's a lot of areas where there is payer flexibility in how you report. We understand, payers' own data system, businesses are different, so you'll see those areas of flexibility denoted by this icon in the manual. This manual and these specifications, it is a one-size-fits-all, and we do have a lot of payers and provider organizations. The nature of contracts is very different. So we are hoping our guidance helps provide enough information where you could, fit it to your organization in a way that makes sense to report spending to us. So anyway, that's just all we're saying here. There is some flexibility in preparing this data. Next slide, please. All right, so probably one of the big discussion topics for this program is attribution. We want to call out manual pages 5 through 12. Our attribution section has greatly increased this year because we've added the IPA and contract name. And I want to give Sam time to talk about that. So I'll just briefly go through. Please check out those pages in the manual. This table over here is just showing that we have 3 attribution tiers, and payers, when you are assigning members to provider entities, should go through this in order, 1, 2, 3. So there is a hierarchy. The first is member selection. So a member actively selected a primary care home for themselves. Tier 2 is a contract arrangement. So members that couldn't be attributed to Tier 1, if you are able to attribute the member to a medical group, provider organization, pursuant to a contract between you, the payer, and the provider, you should make that attribution. And when you report the member spending for that provider organization, you should use attribution Tier 2. Tier 3 is for members who couldn't be attributed using the above tiers, but maybe based on member utilization, can be attributed to a provider organization. So let's say, and maybe you might already have an internal algorithm doing this. And if you do, definitely feel free to use that. So this is a utilization-based algorithm. Let's say you can see based on their utilization that this member is seeing this provider for they're basically using them as a primary care provider. So if you can attribute a member using that way, that is tier 3. Sometimes people can't be attributed. And if not, aggregate those costs in tab TME unattributed. Next slide.
Oh, I just wanted to say,
Oh.
I want to underscore for tier 3, the utilization algorithm. If you have, as a payer, if you've shared some data with a provider that has a list of members that are attributed to that provider and that uses your utilization algorithm, like trying to piggyback off of that, like matching the data you're reporting to us as closely as possible with data you're reporting to the providers will really help on the provider side on the back end, because that is something we've heard quite a bit from providers, that oftentimes the data that is submitted to us will be different than data they actually like got from a payer, because you have some sort of contract and they want to know what members are actually attributed to them based on this algorithm, or try to align that as much as you can. I'm sure you are. You're not like coming up with some brand new algorithm just for our program. At least I would assume you're not doing that. Just piggyback off that and try to make sure they're aligned as close as you possibly can. I think that would really help a lot of the providers. I'm sure they would want me to underscore that for them.
Thanks, that's great. All right, and I'm about to hand it off to you again, Sam, but this is just another slide trying to diagram out member attribution. And here we're also talking about how to find the TINs to report in tab 9. So this is a pretty simplified diagram of going, and so this diagram goes from top to bottom. You have your member. Let's say you were able to attribute them to a PCP, an individual clinician. And then hopefully you are able to associate that provider with a provider organization, an entity, and report on that entity, that organization in the TME tabs, and also the TINs for the organization in tab 9. So again, this is, we're pretty good now, but yeah, we really want to stick to using provider organization to let people know that reporting in these files and for these programs where we're talking about provider organizations, provider entities with TINs. Okay, and here I'll hand it off to Sam. I do want to note, Sam, we have 10 minutes.
Oh my gosh, okay.
Yes, but we do want to talk about this new data field of IPA and contract group.
Okay. I thought we were going till noon, so I'll try to make it fast but comprehensive still. So I think we've covered a lot about why we're adding the IPAs and the contract group column, or like where that's being added. I don't think we've covered why or maybe when. So this is just us trying to be responsive to things we heard from the provider organizations. A lot of them aren't going to be on this call, so I'll try to summarize. A lot of times they were feeling, some provider organizations were feeling like they weren't getting the full breadth of members that should be attributed to them, the actual people coming through their door, because we were asking you, the payers, to use the cost of care, the total cost of care contracting as one of the tiers, as one of the tier hierarchies. And some of those total cost of care contracts are for organizations that don't actually see any patients. They're not for primary care groups. So an example would be if there are a number of pediatricians that are all under one IPA or total cost of care umbrella, and a payer contracts with that organization, but that organization, that umbrella organization, doesn't actually see any of those patients. Those patients still make their way down to these pediatricians. And so we know that that umbrella organization has something to do with the total costs that are associated with healthcare, right? We know that they are negotiating contracts and dictating care in some way, even though they're not providing that actual care. So we want to, and we have always intended to, include IPAs and these contracting organizations as one of the accountable entities. So it's not just payers, it's not just providers, it's everyone that's in between. It's everybody that's trying to get in the middle there, and that has something to do with the cost or maybe the utilization or how care is handled. So that's what we're trying to be responsive to. It might make things seem significantly more complicated for the payers, but I want to be clear that this is not a column that needs to be filled out for every organization or for every member. This is only for specific circumstances where you can identify exactly what I kind of just walked through. We had a few meetings on this in the tag. It seems like the payers, you all for the most part, are understanding of what we're asking for based on the feedback that we're getting and the kind of the back and forth. It probably helps that it's an optional column, but we do want to encourage you with as much specificity as possible to fill out that IPA column, that total cost of care column, if you can, if you know there is an IPA that is not actually providing any care, but the care is actually being provided at those at the like in my example, the pediatrician level. There's a very handy contracting diagram that we laid out that you should be able to walk through this and be able to identify whether or not you want to include the total cost of care contracting entity or the IPA entity, and then what tier each of those provider and IPA combination entities should be attributed to based on the hierarchy codes. So that's the hierarchy codes being tier 1, tier 2, and tier 3, and then unattributed on top of all that. So because we're short on time, I'm not going to walk through all my examples, like all the stuff that we did over the past couple months, talking to you all or emailing back and forth. If there are any questions in the comments or in the chat, I'm happy to jump in there and answer as many as we can. But because we're low on time, and because we've kind of been hitting on this throughout, hopefully this makes sense, and hopefully you all have a good idea of what we're looking for. This this decision tree is available online. We did post that, and it'll be a part of this this presentation as well. So again, that TME Prov, that number 4 column over there, it's free text. You can enter whatever you need to in there. We might come back to you if there are conflicts between payers and there are different maybe total cost of care names. You're using different names for the same IPAs. We might need to work on this system a little bit this year because it is new, but this is just us trying to get to the point of actually tagging the cost to the actual entities that are doing the negotiating or, in charge of actual rising costs, or, maybe give credit to contracts that are keeping costs low. So that's what we're getting after. And if you have any questions, I'll be in the chat or you can reach out to us. I'm also gonna just very quickly mention demographic adjustments. We're gonna continue doing risk adjustment as a demographic only adjustment. That's for all the reasons that we've talked about in the past. It's fair to both payers and providers. We have paused the update. We were saying we were going to try to update the demographic tables this year. The reason we're doing that is because of COVID, essentially. The data that we would be using to update these demographic tables specifically for Medicaid and commercial, it might be not the best data to be using into the future, because we would be using public health emergency data where determinations were not a thing. And, we don't expect the illness burden and the acuity that happened during COVID to continue into 2023, for example. So we're going to stick with the factors that we used that were from 2019 that were pre-COVID demographic tables and demographic factors. We feel pretty good about that. If you have any concerns about that, please reach out to me. I will be doing some analysis, and we might share some version of that depending on what we find about differences between demographics before and during COVID. That could be interesting. But we feel pretty good about that. So if you were hoping for a big update for the demographic tables, it's not going to be coming this year. We'll be looking into it next year. We're going to try to stay on the ball here. Okay, I think I went through that really fast, but hopefully if you were waiting for updates about demographic tables, that it's forthcoming.
All right, thanks, Sam. So I'm gonna sort of run through these last slides. All right, so this is all information from the manual. So it's all in there, but you know, the manual is big, so we do want to call it out here. This, if you look on manual pages 17 through 18, we do have inclusions and exclusions. I don't think we've changed any of this year, but if you look at those tables, you could see types of payments that are not relevant for total medical expenses, the way we talk about it in this program. There is a table there. There is CCO specific guidance on what to include in your spending and what to exclude. Next slide, please. Data completeness for claims and non-claims, please allow for an 80-day runout. So the earliest payer you all should be pulling the data, the earliest is the end of this month, to allow for that 180-day runout period after December 31st, 2023. Another reminder, this is spending for services. So this is reported based on the incurred date of service, not the paid or reconciled date. So this is when the service happened. So we do know, you know, there may be a period of adjustment. So we have some guidance about claims completeness, and then especially for non-claims estimation, you are allowed to estimate non-claims because we realize some of those payments do take a while. And if you do, we may request additional detail for you about that. All right. I'm not going to read through this, but carved out services and vendor payments. This is particularly relevant for commercial partial claims. So for some benefit plans, there may be services like behavioral health and pharmacy that a payer will contract out to the administration of it, contract out to a third party. So if you, the payer, don't have full insight onto those claims, you are allowed to estimate it. And if you look on manual page 21, you'll see some guidance on how to do that estimation. I think a lot of payers use their full claims population to estimate partial claims. All right. And then just to highlight the medical pharmacy section in the manual, that is page 47. So you'll see a more detailed write-up of this new data reporting section. This is just the same information we shared with you earlier in the presentation. All right, I do want to touch really quickly on data collection and validation. Files are due September 6th. If your file is ready a little before then, go ahead and give us an email. I think we're trying to tweak some of the validation processes on our side, but give us an email if you're ready early, and we might be able to run your file a little bit earlier than the due date. Okay, next slide. Validation, there's really no change in how we're doing validation. We have the initial stage 1, stage 2, and then stage 3 is when we meet with you. Sam, can we go to the next slide? And next slide. So stage 1, there you are able to do a self-check before submitting the file to us. And if you go ahead, Sam, to the next slide, I just want to highlight these two tabs, data validation and provider check tabs. We're out of time, but if you look at the other slides in this PowerPoint, which we'll post very soon, if you look at the other slides in this PowerPoint, we walk through how to view those tabs to make sure that the data you entered is correct and aligning with the formatting. If you go ahead, Sam, maybe there's an example of a validation tab. Let's go ahead. Yeah, so here's just an example. And in these slides, you'll see we point out what value we're expecting. So these categories, these columns should equal 0 or close to 0. Yeah, so let's keep going forward. I think those are the last slides, the data validation slides. Let's go to slide 70, and I just want to mention really quickly validation meetings. We are intending to have them September, October. we're going to try to wrap it up end of November. We'll see, but definitely we want to validate these files before the end of the year. Next slide, I think, is just the online submission materials. It's in the same place as before. Let's go to the next slide. There's our email, which you've probably seen many times before. And then also we have office hours, same as last year. So as you're compiling this file, if you have any questions, we will have time to where you could ask us questions and we'll give you answers July 24th during the TAG meeting and also August 14th. So keep on the lookout. We're going to send those meeting invites soon. And that is it. Thank you. We're 2 minutes over. Thanks, everybody, for coming to this year's data submission webinar. And we look forward to your files. Thank you.
Thank you.
Thanks,
Bye.
everybody.
Bye.
Thank you. Bye.